Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Assalamu alaikum. My name is Muhammad Farooq Nizam. I'm a physician here in Edison, New Jersey. We are bringing in the second community health special. If you recall, the first one was presented at the end of March, and from Masjid Al-Wali, this is the second one. I thank you all for joining us tonight. I would like to start by thanking the Masjid Al-Wali and the New Jersey community for flattening the curve and reducing the amount of corona cases by practicing social distancing and adhering to the statewide lockdown. When we had last spoken in the end of May, at that time, the worldwide affected cases, positive cases was about 580,000 with about 26,000 deaths. At present, worldwide, there are 11 million cases with over 500,000 deaths. USA has over 2.7 million cases and over 128,000 deaths, while New Jersey has over 172,000 affected cases with over 15,000 deaths. New York and New Jersey were affected early, and with the lockdown, the number of admissions and new cases has decreased in New Jersey. With the reopening strategy, the concern is about increasing numbers or the second wave. The cases in other states, including Texas, California, Florida, are rising drastically. We wanted to give an update after reviewing the past 3 months of what we have learned medically. And we are actually one of the 4 states that have steadily reduced coronavirus cases in the entire community. As of last week, states in the Midwest and the South, like Florida, have surpassed the amounts of virus cases that we had in New Jersey. However, new corona cases in the country have rapidly increased recently as other states have failed to maintain social distancing and lockdown procedures. We, as a community in the Masjid, have to continue to keep up with the hard work that has been done and to continue to adhere to the guidelines that we have. Just one thing that I do want to say is that so far, whatever the Governor Murphy has done for New Jersey has been working. And that is very important, at least for central and northern New Jersey, where the cases were very high and they're slowly decreasing. I have 2 of my esteemed colleagues who I'd like to introduce who are at the front line in the hospital dealing with this disease. We have Dr. Muhammad Hasham, who is an infectious disease specialist at JFK Medical Center. He's board certified in internal medicine and infectious disease. We also have Dr. Muhammad Zubair, who is a board certified internal medicine specialist and also pulmonary, critical care, and sleep medicine specialist. The 2 respected colleagues have been at the front line in this war against COVID-19, and we wanted to share their expertise, experience, and suggestions, as by now, basically, they've seen every and all types of presentations. On behalf of Masjid Al-Wali, I would like to welcome both of you and also thank you for your time. First, we'll start with Dr. Hasham. Dr. Hasham, we spoke in the end of March. At that time, we did not know much about what COVID-19 was, and the modes of transmissions and everything were not that clear. What do you think what's the source, the mode of transmissions, and the presenting symptoms that you're seeing right now as an infectious disease specialist?
Yeah, so for modes of transmission, it seems to be droplet and respiratory droplet mostly. And what we're seeing in terms of presentation is really a wide range of from people who have no symptoms at all, and we're finding them simply by having them do the test for whatever reason they need to have a test done, if it's for a medical procedure or for screening purposes, if they were exposed to somebody, for example, in the hospital. And then we're seeing it anywhere from no symptoms at all the way to where people are ending up on the ventilators and dying on the ventilators, and pretty much everything in between, from mild cough, fever, shortness of breath, muscle aches, joint pains, stomach symptoms like nausea, vomiting, diarrhea, to, again, all the way to the point where they can't breathe and they need to go on oxygen, and then end up on ventilators in some cases, extreme cases, unfortunately. So it's a very wide range of symptoms, from no symptoms at all the way to respiratory failure.
And what are the symptoms that you're seeing, Dr. Zubair, on presentation, both in the hospital settings and the office settings?
So as Dr. Hasham already mentioned, that some of the patient really, we don't see much symptom at all. And these are the one very dangerous patient who we call a spreader, that they don't even know they have disease. And that's why I want to a little bit stress on that point. You can have your colleague, your friend, your family member, totally asymptomatic, who is mingling with you. That's why the mask is becoming more important, and especially with our masajids and with our family gathering. You can have your own loved one who has no symptom. So before I go to symptom, I think asymptomatic presentation is a very important, we as a community to understand. And in the prayers and Friday prayers and gathering is the one of very common way of exposing ourselves, and that's been proven in the internationally that faith-based communities are the source, and that include all kind of faith with people are gathering. So I want to stress on that point that we need to understand. That's why I think all the masajids, they want to make sure that everybody who comes in there, they have the mask properly placed in when they come in. So the symptom I'm seeing, because I am pulmonary critical care, are office-based. They come to me, body aches, pain, cough, and shortness of breath. When I see them in the hospital, they have a fever up to 101 to 105, and cough, shortness of breath, chest pain, myalgia, aches and pains. Very commonly, I tell you, patient tells that they feel 40 years older and they can't even move. Body is totally beaten up. And then we call it very commonly in this term, new term came called happy hypoxemia. Patient's oxygen is 80 or 70, but they look okay. They don't feel bad. The next couple of hours, they end up on the ventilator and respiratory failure. And believe me, I've seen some of the patients within hours and days, they are gone, they are dead. So this disease is so mind-boggling to us that we cannot predict how patient will do after presentation. So from asymptomatic, no symptom, to death, we cannot predict. That's why this disease is so serious and scary to the community. That doesn't matter, you are young, you are old, you have other diseases. There is chances if you get it, the mortality is high.
Also, just to give everybody an update, we're also seeing gastrointestinal symptoms as presentations with nausea, vomiting, diarrhea, in addition to the lungs, the pulmonary, and also diffuse aches and pains. One of my patients who actually came to me stated that it looked as if somebody took a baseball bat and hit me on the back because I was so sore, my whole body was aching and so severe. Also, we have been seeing a lot of neurological symptoms coming up with them. And we are seeing a lot of people who are confused, delirious, they're having psychosis, but also a lot of people have presenting with ischemic strokes and also intracerebral or brain hemorrhages or brain bleeds. And those are more in the younger people, and they're usually turning out to have inflammation of the blood vessels of the brain. Heart attacks and inflammation of the heart, these are all the other presenting signs that we've been seeing. So initially when we thought that it was all just fever and cough and congestion, the symptoms have now basically involved any part of the body and very rapidly progressing. Am I correct, Dr. Zubair?
Yeah, definitely. No question about it. I think just to add into it, one of the other common things are which the loss of smell and taste are coming before even having any other symptoms. I can tell you some of my patient comes in, they're not just feeling well and they are falling. And their blood pressure is okay, but they cannot just walk properly. And whenever you stand them up, they cannot keep the balance. And the diagnosis was COVID. They had the coronavirus. So really, there are common diseases which we're picking up, which we just mentioned. But there is presentation we are seeing in this population, which is from discoloration of your skin with the muscle pain to now they added new diagnosis, new symptom, which is rhinitis and stuffy nose, which we thought in the spring are only allergy related or other viral illnesses. And now coronavirus is doing that symptoms too. So right now, any symptom which we discuss, you better isolate yourself from your own family, isolate from the community, seek help, get the testing done. Even, you know, another point which I want to make is here, people feel like, oh, I gotta run and do the test right away. More important is isolate yourself, isolate your family. Don't go where your loved ones, your family, and your community is. Be brave and care about the community and say, you know what, I have these symptoms, but I gotta isolate myself. I think I'm gonna stress that to the community. You have headache, isolate yourself before you do anything else. You have runny stuffy nose, body ache, isolate yourself. That you will do service not only to yourself, your loved one, but to the whole community.
Thank you, Dr. Zubair. That's very important. Dr. Hisham, when we spoke 3 months ago, testing was very infrequent. The test results would take 7 to 10 days to come back. But now things have changed. Can you tell us a little bit about what type of tests are available and how long the turnover time is for most of the tests?
Yeah, we've come a long way in terms of the turnaround time. We're getting, in some cases, we're getting results within 20 to 40 minutes. And I think the longest we've had to wait is, 2 days, where we were, when we last spoke, we were waiting weeks sometimes to get the results back. In terms of what tests are being done, so right now there's a PCR test, which is essentially what it does. You take a swab either of the nose or the mouth, and in some cases, if they have a breathing tube in the neck, they'll do it from there. And the patients that are in the hospital who are on the ventilator for a long time, they have what we call a tracheostomy, where the tube is in the neck. They'll swab it from there. But the test has always been the same in that it is this PCR test where they will take a swab with a long kind of the cotton swab kind of thing, and they send sample off to the lab where they will try and amplify the remnants of the genetic material from the virus. And that hasn't changed in terms of how effective it is in finding the virus. It's anywhere between 94 to 99%, depending on which of the different companies is being used. One thing though, and that I think is important to mention about the testing, is that in certain situations, it can take quite a while for it to clear, meaning to get a negative test, even after someone has completely recovered. And nowadays, we're seeing more of that as people have recovered, at least in our area. Those that have recovered are going back to work, and their employers are requiring negative testing. And they get swabs and they're coming back positive, and then they're coming to me. I'm seeing a lot of these patients in my office setting as well, and they need me to explain to the employer essentially why this is happening when the person is completely fine. And one of the downsides, if you will, of the test is not that it's a bad thing, but because it's so sensitive in picking up trace amounts of this genetic material, which we will call RNA. And human beings, we have DNA, but the virus has RNA, but it's the genetic material, that it will take even a slight amount of that and amplify it, and so that the machine can detect it. Now, that's not live virus, that's dead virus remnants of it that are still in your nose or in your mouth. And it's coming back positive, maybe weeks, sometimes months later, I've seen. But that doesn't mean that the people have the virus. So in the beginning, we needed that kind of test, and we still do for asymptomatic patients and those that have symptoms, but we needed this kind of a test so that we could get it, we can catch it early on when there's not a lot of um, testing available and not good testing available. This is the test we had. There is another test now, a blood test, which is an antibody test. And that is helpful in this very situation where you have a positive nasal swab or throat swab. And what you do is to almost prove it to somebody, you do the blood test, which looks for antibodies. And antibodies are the body's own cells, fighter cells, that have formed to fight this virus. And they can take weeks for your body to mount this kind of response. But it is a way to prove that you've recovered from the viral infection. And that's actually being used to decide if you can donate your blood to people who are fighting coronavirus right now, because those antibodies are what we will use, and or those that are affected from the coronavirus, those antibodies are what's going to be used to fight the virus. So antibodies are the next test that we have, and that's through a blood test. So the first test is a nasal swab or a throat swab, and then the antibody test is a blood test. And those are the tests that we have now.
But in the blood test, they're also doing the IgG and IgM. Does that make a difference?
So it's better not to check for IgM. That can lead to confusion. But what it is IgG and IgM, that's short for immunoglobulin. Those are antibodies essentially for, or proteins that are antibodies in the body that we use to fight the infection. So there are different kinds, and we have several IgGs, immunoglobulins. There's IgG, there's IgM, there's IgA, and there are others as well, IgE. So in terms of viral or infections, the two that are relevant to us are, as you mentioned, IgG and IgM. And essentially they come in different timing patterns. So IgM is usually formed earlier on in the response, the infection response or the antibody response. And IgG, if you will, the way I usually explain it to my patients when it comes to IgM and IgG is if you think of the early army, the one that's released, they're your IgM soldiers right there. And then the IgG is your reserve forces that will, the IgM will send a signal back to the main base and tell them this is the enemy that we're fighting, and form your soldiers to train against this kind of enemy. And those reserves are your IgG. Once you've mounted an IgG response, essentially you have antibodies, and that's what are being used when people are donating their blood to people who are fighting the coronavirus. They're using their IgG antibodies to fight the infection. IgM is it's still early on, so you want to see IgG. You want those IgMs converted over to IgG, and that's when that's the most helpful for our purposes.
Oh, that's very informative. Dr. Zubair, when these patients come in, previously they would have shortness of breath and cough congestion, and they would rapidly deteriorate. And as you had mentioned the term happy hypoxemia, they started desaturating. They were thought to be pneumonia before, and they were being given antibiotics and everything. What are the thoughts now? There's some people say that these are more of a vascular picture, and they will be using blood thinners. What are your thoughts on that?
So thank you. Just add what Dr. Hasham said, two important points which I think important to communicate are if you have a symptom, which is a body aches, pain, fever, and you get the test done, which is a swab test, and it comes back negative. So what I want to stress on the community is make sure don't just go and enjoy and say you don't have a coronavirus. We do have, as Dr. Hasham alluded to, maybe 5 to 10% swabs coming back false negative. If your symptoms are there, you have a fever, headache, body ache, pain, and you think you living in America, even anywhere in the world right now, yes, there is a good chance you have a coronavirus, good chance. So I will say to you at that time, either repeat the test, but more than anything else, keep isolating yourself until your symptoms go away. The second point comes in, nobody exactly know how long this virus stays in your system to give you infection. It's an individual. So even though you are better, but after 2 weeks, 3 weeks, that does not mean you take away your mask and don't use anymore. You continue use N95 masks, especially I think if you are proven coronavirus positive. So answering your question, Dr. Nizam, so the patient, when we saw these patients in April, May, who are with the pneumonia, hypoxemia, high fever, going into septic shock, we were really puzzled and totally taken away with the European studies and Chinese study told us that use the chloroquine at that time very commonly and then do not use steroids. We did use limited interleukin 6 at that time, but by end of May or so, I think in the United States with our own experience, we realized that when the cytokine surge happened, in other layman term, inflammation in the body happened. The mechanism is when we get exposed to the virus, our body fight. Like Dr. Hasham said, our police go there and create a fight. That fight does a lot of damage in the area and the most commonly the lungs, but other parts too. And that is that battle causes the damage to our own body. So then European study came, our own experience started telling us that we gotta use steroids, hydrocortisone, which can suppress that cytokine and that's inflammation. So now our practice is changed from the last couple of months that these patients who have shortness of breath, has a pneumonia, one of the things we do is steroids. Other things which we also started, like Dr. Hasham also just mentioned, convalescent plasma. What is that? It's a immunity which patient who already been infected, recover, got better. We take their blood and separate plasma antibodies and give to our patient. So far, what our experience is, we're seeing there are good results and studies coming out showing there is a good result of that. Third one, which I like to mention, is the antiviral medication, remdesivir, which also showed that does not cure it, but it decreases the number of days of sickness. So it helps the patient to recover faster, few days faster than what they historically would recover. I think these three things made the difference since we're looking at April and May, and now we are in June and July, and I think that's improving the patient's condition and mortality. What we used to think, the ventilator used to be key part in April, May, even early June, and now we are thinking, try not to intubate, put these patients on ventilator. It's okay to see hypoxemia, even little low oxygen, because what we realize, if you guys remember the word proning, that half patients sleep on their stomach, so they can open up part of the lungs which is not being used another part which is sick, they can rest it, and somehow their oxygen get better and the patient recovers. So similarly to that, if we do not put the patient on ventilator early and on, we are able to mobilize their secretion. They can cough, they can breathe better. Breathing themselves is better than on ventilator. Of course, when nothing works and they are at the level that they cannot breathe, we have to intubate. But we are seeing more and more patients who we can avoid the ventilator doing better. And I think that's also a different strategy than what used to be before.
Thank you so much for that update. Dr. Hisham, what are the treatment protocols that you are using for infectious disease for people who are coming with fever and aches and pains and all the symptoms we discussed?
Once we've confirmed that they have the coronavirus, or COVID-19 rather, then there's no real algorithm that we're following. It's kind of more of experience based. I don't think anything's been established yet as to the way to go, but just from what we've been doing, we start typically, at least at our hospital, we're starting with the plasma first, and after that we'll try the remdesivir, the antiviral. There's also the Dr. Zubair mentioned the IL-6 inhibitor, tocilizumab, and there's another one in the market too, and steroids. We try and get the plasma and the steroids earlier on, and then if that doesn't resolve the situation, meaning that these patients, let me backtrack a little bit. The ones that we would be treating with plasma and in some cases the steroids as well, are those that have symptoms. So not the asymptomatic patients, not the ones without symptoms. And we are, like we talked about earlier, we are finding those without symptoms. So those with symptoms, that are the fever, the shortness of breath, low levels of oxygen on the monitor, those are the patients that we're treating. Now, what we treat with can vary from hospital to hospital and from doctor to doctor, even within the same hospital. But essentially what I've seen people doing, and what I've been doing, Dr. Zubair has been doing, is starting with plasma and the convalescent plasma, which what we talked about, the antibodies, getting that on board for the patient, starting that, and then steroids as well at that time. And the steroids now is shifting towards Decadron, which is dexamethasone, which is a different kind of steroid, probably a little more potent than the one that we were using initially. And after that, we'll go to the remdesivir, which is the antiviral drug, and the tocilizumab, which is an anti-inflammatory drug. All of these medications that we give come with potential side effects that we always have to discuss with the patient or their family member before we proceed, because they're not without problems. So that's why we reserve them for patients that actually meet certain criteria. So every hospital system, it seems now, is releasing different criteria for medications, such as the remdesivir. You have to meet certain criteria with your oxygen levels, your what we call inflammatory markers, where we can check levels of inflammation in the body. And then based on the criteria, they'll actually tell us whether or not the person fits criteria. We have a little bit of leeway with the criteria as well. Sometimes, our clinical judgment would also be factored into that. And so that's why, there's no set algorithm, but that's where we go, and we try and escalate in terms of the treatment from what we feel is the safest to start with, and then more invasive and potentially more toxic medications as we go, as the person may or may not be sicker. And then there are some cases where I've heard, I haven't had a patient yet myself that needed it, but I've heard where convalescent plasma would be given again a second time. after having had it the first time. So where that actually fits in, I'm not so sure, but I have heard of that happening as well. I have not had a patient yet that needed it, but that would be the way that we would go, stepwise fashion. But again, this can vary between doctors in the same hospital. They may try and get the remdesivir on board. Some of it is also logistics of the hospital. They may prefer um, you follow a certain way as well. I've had, in my experience with the remdesivir, I've had patients who develop kidney problems on it, and so we need to, and it's not everybody, but it seems to be an issue. So, uh, that we have to monitor the kidney function, we have to monitor the liver tests. So all those things have to be taken into account when we're deciding where to go with the treatment. So, but like Dr. Zubair said, the remdesivir did show that it decreased the length of the illness, and so it's an important part of the treatment plan. And that would be after the way I do it again is after I give the plasma and I start steroids, or we have somebody, usually pulmonologist and lung doctor is starting the steroids, which we would agree with, obviously. Then we go to the next step, which is the antiviral, which is the remdesivir. And in certain situations, we would use the IL-6 inhibitor as well, the tocilizumab, and go from there. I've also had situations where remdesivir was given in the beginning. Again, that part comes into how it works with the pharmacy in the hospital, because you can't, in certain situations, they don't want you to give everything in one go, meaning the plasma and the remdesivir at the same time. But those are minor details and idiosyncrasies of the pharmacy department, for example, or hospital, for example. So, but yeah, that's the way I would do. That's the way I have been doing the treatment for my patients. I start with plasma and steroids, and then I escalate up to remdesivir and the IL-6 inhibitor.
Now, there are two things that I wanted to just stress on a little bit. One is that there's a lot of work, as you had mentioned, about the plasma therapy, convalescent therapy. What is the criteria of using those? Who are the patients who are eligible to receive those therapy, and how is it done?
So the plasma is through, we have a drug trial. We have a trial right now through the Mayo Clinic in Minnesota that many hospitals, I think just about every hospital now in this area that I know of, is enrolled in. And essentially it's very liberal in terms of what kind of people can get the plasma, and the criteria is very open. You have to be over 18, and there's not a very strict criteria from what I recall, and I can't remember completely off the top of my head, but there wasn't a lot of limiting factors in who can get plasma. In terms of who can donate the plasma, you have to have that's I think a little bit more strict than actually who can receive. Obviously, if you're receiving, then you have to have you have to have a positive test. And I did hear recently that if you're suspecting that you may have COVID, you may still qualify to get plasma even while you're awaiting the test result. But I'm not so sure about that myself. I was hearing that that may be the case, but I don't know for sure. But in terms of who can donate the plasma, the criteria was quite more strict, and you have to have had a positive result documented, and you had to have recovered, and you have to have antibodies where they would check your antibody level, whether or not you had the IgG or not, and then you would be able to donate. And there are certain criteria for who can and who can't donate. I've had someone tell me that they were screened and then they were told that they're not, they don't qualify, and it's someone who had recovered from COVID. So there are different criteria, but again, the Mayo Clinic criteria is up on, I think it's on their website, but it's easily found in terms of who can actually receive and those that are allowed to donate.
Also, there's a lot of news going on about the chloroquine studies. Initially, it was touted to be a very promising drug. Then the actual studies from Europe came out and they said that they were not effective. And then just, I think yesterday, the study that came out that shows some promise. Did any one of you want to say anything about chloroquine? Have you used it personally and any of your patients?
I've not used it on myself, but earlier on when it first came out, that limited um, patient data from Paris, from in France, where they looked at hydroxychloroquine with Zithromax. After that, I think everybody that I know was using it for their patients, and then as we got more information, we kind of went away from that. In terms of the study that you're alluding to, which is from Henry Ford Hospital in Michigan, that was a retrospective study. I haven't looked at the whole study yet. I just read the reports about it, and that showed that they had some benefit. They had benefit with using it on certain patients, but I would wait until I could review the whole study myself. You know, generally speaking, in medicine, uh, when we're doing when we're looking for treatments, we prefer randomized prospective clinical trials that are double blinded. Retrospective studies are those are more of a challenge to kind of extract what exactly the benefit would be. Again, those are observational studies. When you are trying to determine whether or not a medication or a treatment plan is effective, you want it to be double-blinded, where the person giving it to you doesn't know what they're giving, whether it's the actual treatment versus a placebo or standard treatment that they would use in other patient, and you can't know whether or not you're getting the treatment or the placebo versus the standard treatment, and then let it go forward and see, well, who benefits and who doesn't. That's typically the way we would um, determine if a treatment plan is truly effective. This study, I believe, again, I have not seen the study, so I've read just the report about it, that it was a retrospective study. I believe it was retrospective, right? You all know about it as well. Correct me if I'm wrong, but it was a retrospective study, which is not a randomized trial. It's an observational study where they will go back and look at, okay, who got the hydroxychloroquine and who got azithromycin and who got something different and how did they do. Those are a little bit more difficult to kind of extract benefit from. So extract who benefited from treatment versus not. So I would wait until we get more information from the study itself, and I have to look at the whole report myself, the whole study, and read it before I would make any judgment call or decision on whether or not the hydroxychloroquine is truly helpful or not. And there's you know, some potential problems with that drug because it does affect the heart and the heart rhythm. And I personally did see certain patients where their heart rhythm was affected by the medication, and the medication you know, can last for a long time in the blood. So we have to be careful before I think we jump back to that, until we know. I think there are some more studies that are coming out, you know, that are looking at this. I think when we have that information, I think it would be in a better place to make a judgment. But I'll let Dr. Zubair speak on this as well, because I know he's looked at this as much as any of us in infectious disease have, because we've all kind of been in the same boat. So Dr. Zubair, uh, have you had any issues with the Plaquenil as well, and about this study this retrospective study?
Yeah, just to answer directly that question, I agree with you what you said. I think we have to be very careful with the plaquenil and chloroquine use. We know that many patients who died with cardiac arrhythmia with coronavirus were on these medication, and there is cases with a sudden death. Some of them were not even on the monitor, and that was expected. Those patients died. Yes, they had a coronavirus, but the key was that what else they were on, and the cardiac arrhythmia were much more common in that population than the other patient. So going back, I think another which we discussed, these are the patients who are in the hospital with the pneumonia, with the sepsis. I think one more component is the patient who are home, which is asymptomatic and then becomes minimum symptom, what to do with them. Remember one thing, still we do not have cure for coronavirus. Community and everybody need to understand that one. There's no cure. What we're talking about is making the disease better, making the symptom better, maybe getting some survival better. So there's no treatment for coronavirus right now. Only thing what we can do is social distance and mask. I think face mask is more important than our plasma, than our chloroquine, than our steroids, than our remdesivir. I think face mask is the key part. Hand washing is the key part. Now, going beyond, once you get the coronavirus, you are minimally sick or you have symptoms of body aches, pains, fever. So what do you do? I think first thing, lifestyle. Make sure you have a healthy lifestyle. So healthy lifestyle means you eat right, drink plenty of water, multivitamins. Other things which you can add into is look into vitamin D, look into taking aspirin, look into taking magnesium, vitamin C. Remember, these are not the cure. This is spending and life as a healthy standard life. Try not to go on dieting while you suspect you are coronavirus. Eat good. Take a walk. Don't sit, lie in the bed hours and hours because you are not feeling well. Not good for you. If you want to lie down, be proning position at night time if you can. If you can, walk around in the room, and that's very important. Other thing, when you go beyond that is starting fever, I think the key part is taking Tylenol. Don't let the fever go 103, 104, 105 and then take Tylenol. I think once the fever goes up, it causes its own inflammation. I think it's important to take Tylenol. Don't let the fever go. Some of my patients who I treat them as an outpatient, I tell them, put the alarm clock at night time. They will have a fever 3 o'clock in the morning. They get up with a burning body with 103 fever. I tell them to put the alarm clock, 2 o'clock, get up, take a Tylenol, and you will feel much better. And they have a better night, and that helps them a lot. I think these things are important. These are the patients who are not coming to the hospital yet. They are home yet. Buy a pulse oximetry. Check your pulse ox. Make sure your oxygen is not dropping. If your oxygen persistently dropping, coming down, yes, you need to call your physician and talk to them. If your oxygen stays stable, you are much better shape. Take a deep breath and see if you can hold it. If you cannot hold your breath and you feel a chest pain, not a good sign. That means you need to call your doctor. If you start getting cough and phlegm or not phlegm, not a bad idea to use called bronchodilator inhaler, which patient with asthma and COPD use. I'm sure your doctor can help. Call them, let them know the symptom. And the bronchitis is a very common in this disease. And some patient just ends up with bronchitis. Don't go further. And you can treat that bronchitis at home. Don't have to go. Rarely, but we do use sometimes antibacterial medication if infectious diseases or pulmonologists feel there may be secondary infection, bacterial, on top of viral infection. Just discussing about the treatment. Now, going back on chloroquine and plaquenil is, I think we need to wait, let the final studies come out. The expert in CDC recommend what they're recommending to us. I will discourage people at home, and in the community do not start taking it yet. They need to hear from the expert, and we need to hear from CDC what their recommendation is. As you guys know, until today, CDC took away the plaquenil and chloroquine as a experimental drug, and they do not recommend to take it right now.
Right. So as we just discussed, the updated symptoms that we are now facing with the coronavirus are fever, cough, shortness of breath, fatigue, muscle or body aches, headaches, nausea, vomiting, diarrhea, sore throat, congestion, lack of smell. We are also seeing people presenting with heart attacks and strokes, especially the younger generation. And while a vaccine is still not expected till the winter of 2020, we believe that by adhering to social distancing and public health guidelines, we are on our way to make New Jersey a corona-free state. I will just go with the closing points. Dr. Zubair, do you have any closing points you would like to add?
Yeah, I think the lesson is, as I said before, there's no treatment for coronavirus. Only thing what we can do is social distance. How we create social distances, avoid common public places where we are. I think I tell you, we doing this presentation from Masjid Al-Wali side. I think trustees and community in Masjid Al-Wali done the great work where they were able to isolate the community and really flatten the curve and bend the curve. Still, I will not rush to have the big community together. I will say, keep your distance, use your mask, wash your hands. If you are sick, do not go out in the community. Isolate yourself from your loved ones. If you happen to go out in a larger community and you come back home, make sure you wash yourself, take a shower, check your clothes and shoes separate so that you don't bring that coronavirus at home. So I think you have to be just 24-hour visual about it. Think about it. Wherever you go out and you mingle with other people and close to other people, I think you need to consider, yes, we are carrying it and we need to isolate ourselves from each other. Then we are the winner. We will go forward. Look at what happened in Florida, in Texas and Arizona. And I think key part is they did not socially distance themselves. They did not use the mask. If there's any learning lesson from this whole conversation is, one point you can take away is social distance, mask. If you are sick, isolate yourself from your loved ones and from the community. Thank you.
Thank you, Dr. Zubair. I think Dr. Sham got accidentally logged out. I want to thank both of you for updating the community on this very serious issue. The key here has been maintaining social distancing, washing your hands, wearing masks, and if you do not feel well, call your physician. Do not go to the hospital right away. Our goal as citizens is to adhere to our government and healthcare recommendations in order to fight this virus. As you know that Masjid Al-Wali has opened up for daily prayers and Jummah with limited numbers based on the strict guidelines from the state. It is imperative that we continue to follow the guideline of social distancing, using masks, frequent hand washings to continue to flatten the curve and prevent further spread. Another very important point is that that we had discussed previously that if you get packages or if you get grocery shop, things from the groceries, please leave them outside for some hours because heat and humidity does kill the virus. Cold air will keep the virus in place. Oh, we have Dr. Hasham back in. Dr. Hasham, do you want to say any closing statements? Your mic is off.
Sorry, I lost the internet
Any
connection.
closing statements?
Yeah, so what I would say is, the most important thing, we talk about all these different treatments and everything. Dr. Zubair mentioned this as well, but keeping yourself and those around you safe by wearing a mask is probably the most important thing that any of us can do in fighting this virus and preventing it from from spreading. We talk about flattening the curve and what that means, and essentially, what we're doing is trying to avoid overloading the hospital system. And if we can maintain our social distancing and wearing the face mask, it'll go a long way in stopping the spread of this virus and hopefully eliminating it altogether. That would be the end goal. And that's what I would end with is just everybody, please be smart and wear your mask and keep your distance from everybody.
Thank you, Dr. Sham. One thing I just do want to add that, a lot of our community members are from the South Asian community, and we are seeing the rising numbers in India, Pakistan, Bangladesh. I feel that where we had our first talk in end of March, where we had the rising numbers, that's where they are right now. And I hope and pray that they use all the experience from all the medical personnel, the data that has been coming out from all different areas, and so use masks and social distancing. Because over the past 3 months, I think New Jersey, with the strict lockdown, I think Governor Murphy has done an amazing job of his lockdown efforts, and also the population of New Jersey, majority of them have followed those guidelines. And that's why we are seeing these decreasing numbers by all the recommendations that were made. I also would like to ask you all to make dua for the first responders, the medical personnel, as they are risking their lives to protect yours. And also I'd like to thank you for listening to this Masjid Al-Wali Community Outreach Program. And we'll inshallah keep on bringing these more as we get more information about more studies so that other communities can benefit from us. And we also pray for the communities that are being affected in Florida, in Texas, in California, and other places, that social distancing and the lockdown did make a difference in New Jersey. Thank you very much again, Dr. Sham, Dr. Zubair. Jazakallah for your time.
Thank you. Assalamu alaikum.
Assalamu alaikum.